Uh, it's my pleasure to be here, and it is important that all of us understand the implications of what is going on. Clinical Establishment Act is not something new. Recently, I was asked to give a talk, and the topic given to me was New Kid on the Block. It is something like saying, this is the new kid on the block who has been here for the past so many decades. So if he is new kid on the block, definitely a Clinical Establishment Act is also new kid on the block. Why do I consider this important? This is a very, very carefully thought out fraud which has been committed on the medical profession, taking them to be fools, which they are. I agree. As medical professionals, we are fools, and we have been taken to be fools when this bill became an act in 2010, the Central Act. Punjab passed this act in 2020. Why do I say this is a massive fraud? Look at what has happened under it. In the states where it has been implemented, it is already notified in Punjab. It is not fully operational. But the problem is the government here does not spend a penny on private clinical establishments. It does not pay the private doctors an iota. But they are treated as if they are on the payroll of the government, and they have to do everything which the DC and the civil surgeon and the politician of the day or the ML of the day commands. So effectively, you have given away your independence the day this act was implemented. And how was this implemented? It was first introduced in the parliament by Shri Ambumani Ramdas in 2007, and it was referred to parliamentary committee headed by Shri Amar Singh. This parliamentary committee had totally rejected this bill, that this is not practical. Objections given were that health is a state subject, so a central law cannot come. Requirement about health services differ from state to state, so you cannot have a common establishment act. Bill will push the present healthcare structures, including government hospitals, towards collapse. And the bill will directly increase the establishment costs, so directly escalating the treatment costs. These were the reasons given by the Parliamentary Standing Committee. Now, despite this, with a gap of 3 years, this rejected bill was again introduced in the Parliament by the new Health Minister, Shri Ghulam Nabi Azad, in 2010. And it was passed without a single word of discussion on it. In fact, in the Rajya Sabha, when this bill came, Mrs. Bindra Karat, this is the CPM, she demanded that a factor to control the charges being charged by the private doctor should be included as part of the act. I again come to my original point. The government has not invested an iota into the private healthcare system. They have not provided the land, they have not provided the building, they have not provided loan, they have not provided the equipment, and they are not paying a salary to the private doctor. But under this act, and each and every private doctor becomes an employee of the government. This realization has not hit us so far, and unfortunately so, but it is soon going to be more draconian than PCP and DT Act, which affected only the gynecologists or the radiologists. This will uniformly affect every one of us. And Ghulam Nabi Azad ji had assured her in the act that yes, we will do it. And when the rules were passed, this factor has been included, that the government will decide what charges Dr. Vitull and I charge from my patients. It is not being implemented, but the law exists. It is to be applicable to the states which are already in agreement to implement all central laws. There are 4 states. all union territories once the Central Act was passed. And many states after that have implemented their own versions of the Act. When this Act came, I was in discussion with Punjab IMA on how we should, because Chandigarh, the Act became implemented immediately the day it was notified. And 2012, when the rules were passed, it became operational. Punjab leadership I was in discussions with, and I was assured that we have good political clout that we will not permit Clinical Establishment Act to be notified in the state of Punjab. Haryana, meanwhile, got an amended act notified in which it said that clinical establishments more than 50 beds only will be covered under Clinical Establishment Act. Punjab people tried to do the same. However, this is the 2020 notification of Punjab, and what was missed initially, there was some celebration that now it is applicable only on 100 beds and above. What has been missed totally is that in this act, if you go through each and every clause, the state authority is to register hospitals with more than 100 beds, and district authority is to register all clinical establishments with less than 100 beds. So each clinical establishment, whether it is a clinic, a diagnostic center, an Ayurvedic center, any clinic or physiotherapy center, it is a clinical establishment under the Act, and it is to be registered, if not with the state authority, at least with the district authority. The only thing good I find in the Punjab Act, which was probably negotiated by Dr. Rajendra Sharma Hoshiarpur, I think he was the person who was leading the negotiations. What I could find in the Punjab Act, which was good and which was against us in the Central Act, was from temporary registration to permanent registration. Before permanent registration was given, the Central Act says that a notice, a public notice will be given, and 45 days time will be given for anybody, maybe your neighbor, maybe your competitor, maybe your ex-wife, maybe your whosoever, to give any objection. And then you would be given a chance to reply to those objections. So how many private clinics would be able to get permanent registration with total lack of anybody objecting to the clinic being there? I'm sure in Chandigarh, so definitely my neighbor has a parking problem with me, and somebody else would have some other problems with me. So it was a major issue in the Central Act. This is not there in the Punjab Act. So that is one thing good which has been achieved. The other thing is Section 12 of the Central Act had said that anybody and everybody approaching me in the emergency has to be stabilized. If I am an ophthalmologist and a lady in second stage of labor approaches me, how am I supposed to stabilize? I think the only way to stabilize the second stage of labor is to deliver. And what about people who are semi-retired, who are working maybe 4 hours a day and running maybe only OPDs? How are they to maintain a 24-hour round-the-clock emergency system? And there is no clause which says how you are going to be reimbursed for this stabilization. So Punjab at least has done this. Instead of this, they have said you need to give first aid and try to stabilize and then refer. This referral part is not mentioned in the Central Act. Except army clinics and army hospitals, anything and everything which deals with diagnosis or treatment is covered under the definition of clinical establishment. Whether it is a single doctor establishment or a nursing home. And when I last gave this talk, I was under the impression Punjab has implemented it only on 50 beds and more, but I was wrong. To give the talk here, when I was again researching it, As I said, the state authority is to register 100 beds and more, and district authority is to register all clinical establishments less than 100 beds. So ये free medical camp जो हम लगाते हैं, what are these? Registered clinical establishments? Definitely not. These home visits that we do, this do good nature that we have in an aeroplane, somebody has a cardiac arrest and we go and try and help that person. Is it a clinical establishment? And if I am not practicing in a clinical establishment which is registered, I am penalized. Recently on a flight, somebody had a cardiac problem and they announced, is there a doctor on board? So against my better thought process, I volunteered. I got up immediately and went. But no, the air hostess stopped me. She said, you have to show me a credential proving you are a doctor. No, there is a crisis. I am volunteering to help, but the airline staff wants me to first show the credentials before they allow me to treat. Should we be so forthcoming in tackling these roadside emergencies then? If the airline itself is so careful whom they allow to treat because they may be sued, are we not equally liable to be sued? There are thought processes in me which are more radical than what people would like to hear, but I do not apologize for them. There were a number of nursing home acts which were in existence before the Clinical Establishment Act came, but they were applicable only on nursing homes. As I said earlier, Clinical Establishment Act is applicable on everything, and by everything, physiotherapy, Ayurveda, homeopathy, diagnostic center, clinic, single doctor clinic, nursing home, hospital, tertiary hospital, everything. Objectives: to create a digital registry to prevent quackery. This is the biggest lie I have ever heard. And to prescribe minimum standards of facilities and services. This is the biggest problem I have with Clinical Establishment Act. When you prescribe certain standards, these standards which are not possible to follow by any small and medium healthcare establishment in the country, you leave us open to blackmail and exploitation by various inspectors under various laws. The Central Act requires me to take licenses in 27 different acts. And obviously, every year I have to take a fire safety license. And every time I had a building in Mohali, every time a fire safety license I used to take from them, it used to cost me 10 or 15,000 was the official fee and 30,000 was the under the table fee every year. I'm being blunt. So this is the kind of compliances we are forced to undertake when we are registered as a clinical establishment. And as I said earlier, the government investment is nil. The government gets total control over all private small and medium healthcare establishments and abdicates its responsibility to provide healthcare to its citizens by forcing private establishments to do it free of cost. How many clinical establishments have been registered across the country till March 2024? This is the number. Do you know there is another recognized system of medicine in India called Soarikpa? Had anybody heard of this earlier? Please raise your hands if you had heard of this. This is the Tibetan system of medicine, and as of today, there are 63 registered clinics across the country. And this is a recognized system of medicine in India, equally recognized as the modern scientific medicine you are following. I have a lot of problems with the constitution of the National Council of Clinical Establishment. I can go on and on to speak about this, but Dr. Vitull has warned me that though he generously offered me 30 minutes, he has put a time bar that he will try and push me off despite my bulk off the stage at 11:30 sharp. So, no. The point is, you look at the composition. Clinical establishments. Who are running the clinical establishments? It is the doctors of modern scientific medicine who are providing 70%, 80% of healthcare services in the country in small and medium healthcare establishments. You take out the statistics, the WHO statistics, the National Health Survey statistics. What is the number of patients who are treated in private sector, small, unorganized sector, and what is the number treated in, let us say, government hospitals or even corporate hospitals? The proportion today is still 70% is being, 65 to 70% is still being treated in these mom and pop clinics, where husband, wife stay on the top and there is a nursing home down on the ground floor. These are the kind of establishments which are providing bulk of the services, whether as inpatient or outpatient across the country. Look at the composition of these councils. How many members are there from the modern scientific medicine? Hardly any. How many of these members are representatives of small and medium healthcare establishments? None. One member from paramedical systems, 4 representatives from DCI, MCI. MCI, National Medical Commission, is no longer a representative body of the doctors. It is a nominated body where the government has nominated people it likes. So it is no longer a representative body which is elected by the professionals whom it is supposed to represent. And when you just go on, look at representative each from Central Council of Indian Medicine, one from Ayurveda, Unani, Siddhi, Central Council of Homeopathy, one elected representative from CCIM Association, no elected representative from IMA. But from Central Council of Indian Medicine, the association, yes, you have representatives there. Then nominated members from consumer groups, Quality Council, Northeastern Council, Bureau of Indian Standards. What are we trying to say? You wish to run healthcare without doctors of modern scientific medicine? Be my guest. Try it. Pass an ordinance where we stop working for, let us say, 1 week. And let us see how healthcare is provided in the country. Punjab State Council, look at the members. There are only 3 members who are doctors of modern scientific medicine. How do you work in these kind of situations? And in district councils, you will have representative from the police, from the local self-government, from professional associations, any professional association. It is not necessarily IMA. Many attempts were made to go to court and get Clinical Establishment Act nullified. All of them failed. This was in Tamil Nadu High Court. This was in Uttarakhand High Court. This was in Punjab and Haryana High Court. And we had made number of representations, even on behalf of Medical Legal Action Group, to the government on this, in this regard, and we had not succeeded. Now it is already exactly 12 years since the Central Act has been notified and operational, and I am not very sure whether the rules of the State Act have still been notified. If somebody here can make me aware, I'll be grateful. But the Act has been notified, but the rules have probably, and the standards have still not been notified, which is the reason why you are not having to register your clinical establishments as yet. But this is something which is lucrative, because it gives government officials an option to arm twist you and take money out of you. So this is something which cannot be overlooked by any fiscally responsible government, because even though the fiscal responsibility is supposed to be of what we call white money, but I think all governments are equally concerned about their election funds, and so that usually is not what we talk about in white money. Do you know that Clinical Establishment Act also gives power to award compensation to a patient who complains against you to the authority under Clinical Establishment Act. There are already 14 avenues where a patient can make a complaint against you for professional negligence. If you have not done something properly, there are 14 places where a patient can make a complaint, and at least in 6 or 7 of these, the complaint is made simultaneously. It is not as if you can go to one or the other. And Clinical Establishment Act is the best one, because if your complaint has been made, it is assumed you were wrong. Till the time the decision is made, your clinical establishment registration is cancelled and you cannot see patients in your clinical establishment. This is the problem, the section 12A, the 12C, where emergency treatment was ensured by the Central Clinical Establishment Act. Even MCI Code of Ethics, the Code of Ethics of NMC, which were brought in last year, were withdrawn because of the issue which rose regarding the generic medicines. But this regulation is again ready to be brought out anytime in the near next 2-3 months. And once it comes, it will override what was given in Medical Council of India regulations of 2002, which had told us that in case I find that I am an ophthalmologist and the patient is a delivery patient, I should refer. So at least we had some legal basis then, but this will not be there in future. Already we had number of legal judgments where it is stated extremely clearly that an emergency coming to you, you have to treat. Who is going to pay is not the concern of the courts or the government. One medical superintendent of one hospital, Sundarlal Jain Hospital, Delhi, he gave a directive to doctors that you have to see all patients of roadside accident who come in an emergency. You have to give them first aid. But if you have to admit them in ICU, you have to ensure that 25,000 rupees is deposited. So one emergency came, first aid was given, oxygen was given, IV fluids were given, whatever injections were needed were given. And the patient who had splenic rupture, he was advised that he should be admitted to the surgical ICU. The relatives were asked to deposit a sum of 25,000 rupees. They did not have it. The patient was taken to a government hospital. Before the patient could reach the government hospital, the patient died. Now, a criminal case was filed against the medical superintendent. Please remember, a criminal liability is a personal liability. If I have stabbed Dr. Noheria, only I can be held responsible, not Dr. Vitull Gupta, who has invited me here, and he is not vicariously liable for something I do. So in this particular incident, the medical superintendent had not seen the patient. The medical superintendent had not treated the patient. The medical superintendent had simply given a notice to all doctors that this is the policy of the hospital. This matter went to Delhi High Court and the bail was denied. The case was asked to continue. This is the kind of situation you are facing, and more these issues will arise under Clinical Establishment Act, which is why I say it is more draconian than even PCP NDT, under which more than 3,500 radiologists, ultrasonologists have been penalized either with jail terms or fine or so on and so forth. Multiple judgments on the issue of emergency treatment. This is the section under section 12 of Central Act where emergency treatment is considered. Medical Legal Action Group through Mr. Ravneet Bittu, he was Member Parliament, we had placed our amendment in Lok Sabha Of course, since it was a private member's bill, it was never passed. But we had tried to get some amendments made in the Act unsuccessfully. Similarly, other private member bills were also introduced where one of the sections to be amended was that patients shall not be subjected to any unnecessary tests, shall provide generic medicines, shall display all concessions, subsidies, incentives, tax exemptions from local and central government. Display any conditions. I mean, all these have been, the attempts have been made to make Clinical Establishment Act more stringent, more unfavorable for doctors. And in the rules, this is what has come in, that shall charge the rates notified by the central government and shall display the rates charged. So you cannot decide what rate you are to charge as consultation or as procedure charges from your patients. This is something which is politically very attractive. And all state governments today or tomorrow are going to adopt this in one way or the other. Without having to spend a penny, they decide you have to treat, you have to see your patients for 20 rupees consultation, you have to, it will be legal. This is where I say we should have objected, because this is draconian. How can you decide something on my behalf? Either you pay me salary and then you say, whatever you wish, I will do. The power to make rules also lie with the central government and correspondingly with the state government for state acts. This fixing of rates, I will try to show you an example of how government decides to fix rates. You look at the CGHS rates, Nabi Compendium, most of you will be aware of this booklet. It gives CGHS rates for that particular year. 2010, for pterygium surgery, 75 rupees was being given. 2014, it was increased to 86 rupees. And 2024 to 5,500. At one time, I was being paid 330 rupees for colonoscopy, 550 rupees for sigmoidoscopy. Sigmoidoscopy is much lesser a work for me than colonoscopy. But I was getting 330 for colonoscopy and 550 for sigmoidoscopy. This is how government decides rates, and this is how the rates are going to be decided for you. Whether the patient is cash paying or insurance, it doesn't matter. Look at the rates from 2014 to 2024. 18,950, 18,950. No rate has been increased in the last 10 years. So I can go on and on these issues. The point remains, the control of my professional functioning has been taken away from myself, and it is taken away by the government, by the executive. I mean, I'm all willing, do it, but then employ me. Pay me salary. Why do you want me to invest? Why do you want me to take a loan? Why do you want me to create the infrastructure? And then tell me that this is how I have to work. This is what I should charge. These are the number of patients of dengue I have seen. These are the patients of acute diarrheal disease I have seen. I have to give all these statistics. My point is very, very simple. I am a private clinical establishment, which means I am an independent professional working independently without any government subsidy or support. But under Clinical Establishment Act, I become its employee. That is my biggest worry. Also, you will be given standard treatment guidelines. This is how you are supposed to treat. And if you actually go through the guidelines for your own specialty, you will be shocked at some of the things which are mentioned in those guidelines, which may be against what your contemporaries are advising. There are many impossible conditions. You have to have a prescription audit. Somebody will come and check Dr. Vitull's prescriptions given over the last 3 months, whether what he has given in his prescriptions is correct or not. Maintain information and statistics. I mean, these issues are unending. So I think basically I'll just end this. Look at the type of compliances for a government hospital versus a private hospital. A 10-bedded private hospital has more compliances to follow than a 100-bedded government hospital. Then a 10-bedded private hospital of modern scientific medicine has many more compliances to follow than a 100-bedded Ayush hospital. This kind of discrimination is also something which I fail to understand. Whether this is deliberate or not. Do you know, for a nursing home, it is necessary to have space for a fire engine to go all across the nursing home, around the nursing home? You have to have, if you have a basement, ground, first and second floor in your nursing home, you have to have a tank, water tank of 75,000 liters. After semi-retirement from my nursing home, which I sold, I purchased a house and I built a swimming pool in my basement, and the swimming pool capacity is 65,000 liters. It is less than what I had to create to comply with the fire norms in Chandigarh. Ridiculous. So just carry on and on. Look at this underground water storage tanks. I mean, exit facilities. You have to have ramps. You are allowing nursing homes to function in a one canal plot. In Chandigarh, in a one canal plot, you have to leave 45% of the area, partly in front, partly behind. So the FAR, the covered area, is already very restricted. How can you create ramps in this? Gensets, I mean, and this was 60% of the city. This was a report of 2015. You can't run a nursing home or a hospital if you do not have completion certificate of the building. PGI buildings do not have completion certificates. I have under RTI asked Government Hospital Sector 16, Government Hospital Sector 22, whether they comply with the clinical establishments, and the replies which have been given, look at this. Does the health center have authorization under biomedical waste management and handling rules? Answer is no. But a 10-bedded nursing home has to have that. And this is a 100-bedded hospital in Sector 22, a government hospital. Similarly, Sector 16, which is, I think, 800 or 900-bedded. Again, no authorization under biomedical waste and handling rules, Atomic Energy Board, under hazard waste. All this is required by a 10-bedded nursing home. This part has been deleted by the Punjab state, and I'm happy that IMA Punjab was able to get this removed, that before permanent registration, a public notice will be given and public objections will be invited. At least this is something positive for doctors. And look at the kind of ratio you are supposed to have for each patient, how many nurses. We are asked to provide one nurse for every 6 patients in general ward. And in 2010, DNA was reported, this is a newspaper, that public hospitals in Mumbai have 1 nurse for 60 patients. You are giving compliances which are impossible to comply with. You know very well that anybody who's registered will have to break the law. And once he breaks the law, you know what is going to happen. Some inspector is going to come and he is going to say, Dr. Sahab, aapka to clinic band karna padega. And then you will say, nahi ji, bataiye, how can we avoid this? So whether it is 10,000 or 1 lakh or 5 lakhs, I don't know what it is. But this is something which you are, this is the Inspector Raj which has been brought in. And this is what I feel is, this will lead to nursing homes closing down. Already, Chandigarh had 28, 29 nursing homes in 1999. Today we have 18. 10 nursing homes in Chandigarh have closed down. I know when I was trying to sell my nursing home, I was told by one of the organizations which deals in hospital sale, purchase, and rental that there are 200 hospitals for sale in Punjab at that time. So these are issues which need to be considered by our associations and organizations. And I'm glad Dr. Vitull gave me an opportunity to speak on this. The penalties are enormous. And when I compare with the compliances given for these Ayush and SOA RICPA and homeopathy hospitals, they are just not comparable. So thank you so very much. I think I'll stop here. I have exceeded the time. Yes, by 2 minutes, sir.
No problem, sir. That is most utilized time, I think. And I must thank you for making the people aware about the unknown dangers of Clinical Establishment Act. So we in India, if we go by paper, so this is the best country to live in.
Oh, yes.
But if we go by the ground realities, everybody knows that red light, yellow light, and green lights are the cosmetic lights, and nobody follows. And what you have told, that if somebody is caught, it is just 50 rupees or 100 rupees to get yourself free. So thank you very much. Now we can have one or two questions if there are.
Actually, you see, we all talk about all these establishment and all that. I personally feel, I'm sorry to say, that we are all responsible for all the mess, you see. I think it's the professional people who are responsible. Why don't we unite together and get it all, read it out of it, you see? Because we don't unite at all.